Great. Great. Thank you so much. So Kelly, you have heard and know a lot about. She's a wonderful psychiatrist and so committed to this project and this work that I feel very privileged to know her. I've been associated with the Engage initiative for about 4.5 years now. I came to it because I worked at NAMI, Massachusetts, National Alliance on Mental Illness, and NAMI was contacted to see if we would be interested in taking part in this research and project, and I said yes. And here's why I said yes. I was a caregiver for my mother who had cancer when I was a teenager. She passed when I was 18 from a metastatic lung cancer, which went to her brain. And my father had died 7 years earlier. So at age 18, just 18, I was orphaned. I came from my home to Boston to go to school. Thankfully, I had that opportunity. And I managed somehow to get through college without too many problems. But in my 20s, the depression came to me. And it really hit me very hard. So I've had that to deal with most of my life, or my adult life. I'm happy to say, with the help of some friends, I found a therapist. I was treated. I continue to see therapists right now for the rest of my life. I'm sure I will. I'm taking medication and been able to function. I have 2 grown children and just went from 3 to 4 grandchildren, I'm happy to say. So I'm very surprised to be alive, given the ages at which my parents died, but I'm very grateful to be alive. My interest in older adults came because I thought, I'm going to have to do something that exposes me to older adults, because I don't have parents. I don't know about older adults. So I went to work for the Area Agency on Aging, and worked there for quite a number of years, and learned a great deal about aging and aging in place and aging in the community, and the varied and fabulous personalities of the clients that we saw. So that's always been an area of interest for me, and that's why I'm in this session today. So what I would like to do is have folks think about some of the things that Kelly asked about in her summation just before this. Want to talk to you who have had experience about what your best practices are, what in the past year particularly has frustrated you. And anybody can chime in or use the chat if you prefer. But what are some of the frustrations you've had to deal with in working with older adults during COVID, let's say? Everybody might be muted, so please unmute yourselves if someone wants to speak. Thank you.
Hey, Ruth Ann, thank you. Noreen
Sure.
From Elliott. Thanks. What a powerful start to the day, Kelly. Thanks so much. Amazing, just amazing. Starting sort of with the strength, and I think about working with older adults, and one thing I appreciate is their experience and kind of their life experience. And I think, with some of the stories shared earlier this morning, kind of shows the resiliency, and older adults have experience getting through some things that they can kind of pass on to other people. So really valuing that. I think what's been challenging over the past year for people that we're serving is, again, trying to support people and advocate for people to get access to care. And I was really struck, with that this morning, and talking about that and the challenges with getting access to care. And sometimes we're just, again, trying to advocate and support people, and just sort of shaking our heads at what's happening, and hopefully trying to support people's voices and getting what they need. So that's the frustration I would share.
Mm-hmm, mm-hmm. Yeah, Lee, please go ahead.
Hi. This past year I was working for a Department of Mental Health vendor ACCS program, and I also live in a elderly disabled building in Brookline. And I see, and my caseload was a lot of it was at ACCS with older adults. And what I've noticed is the younger and older adults on my ACCS caseload, the thing that got them the most was either they didn't have money for the equipment, they didn't have the skills for the equipment, and those two, and those two in that population with the Department of Mental Health population who I worked with, that was one segment. People who I live with in an apartment building run by Hebrew Senior Life in Brookline, those people who live in the building have to be 62 or older without a disability. Most of them know how to use the internet.
Mhm.
And we're talking the same age, similar age group. You know, people who move into my apartment building tend to be a little bit more higher income, even though they do take some Section 8s and stuff. So, and they also had the skills, you know, and this is all during the pandemic because I was working remotely.
And
And
I would say your building probably provides internet for the residents that are there. They don't have to.
no, they do their own internet either through
Okay.
Comcast or RCN.
Okay.
My building didn't do anything except provide online programming, you know, like activities online.
Okay.
But the tenants in my building, my neighbors, had their own devices. Where the people are my clients at work, some had their own devices, some didn't have any devices at all. And that period of time, that's when ACCS workers weren't even making home visits because they weren't
Yeah.
allowed to.
Right. Anybody else have any tales of frustration during the past year or so?
My name is Joanne Wolf, and I'm with the Northeast Independent Living Program. And right when COVID hit, that we had to leave work and work remotely, I was promoted to manager of older adult peer services. And it was quite a challenge creating a new department and serving older adults. Basically, I work with 5 ASAPs in the Northeast region, and we had they had passed a law with the elder frail waiver to so that we could be compensated by insurance.
And could you let us know what an ASAP is? I think everybody in the
Oh,
room.
it's an elder agency for older adults, you know, elder services. So places like Mystic Valley, Elder Services of Merrimack Valley, Senior Care up on the North Shore, Minuteman, which is like in the Bedford area, Burlington, and things like that. So, and also Bliss, which is in Lynn. So their towns and surrounding areas. So we started off working with each of them, some, not all at the same time. They came slowly. It was something we had to build towards. And I don't have a lot of frustration. It was a very exciting time to start this program, and it was so needed to meet older adults and help them go through COVID. I mean, isolation and being alone and having loneliness is such a big thing with older adults, and I just found that you know, communicating with them was so important. And most older adults only have a phone. They don't have any type of device that we could do Zoom calls or FaceTime. And I guess if anything was the biggest frustration, probably that, because many of our consumers were met on the phone and not in person. And you can imagine how difficult it is to build a trusting relationship with them. But I think because we do use person-centered language, and we share all of us that work in being a peer specialist, we all have lived experience. So we share our own lived experience to help open things up with the consumer. So they really get to know us and know how authentic we are. And that's key. And so even though I did deal with several people that really feel uncomfortable meeting someone or sharing their own story over the phone, I think just how personable we all are, and how we put ourselves out there really made a difference. And people opened up to us, even though they couldn't see us yet, and I'm very excited that we'll soon, I don't know exactly when, but we will start to do some in person. It's kind of going to be a hybrid
Mhm.
kind of thing where we'll visit them some of the time. But we are constantly growing and, trying to hire more peer specialists to, get this work done and really help older adults. And, working with older adults, I grew up in a large family, not my own family, but my extended family is quite large. And I had a lot of, I had my grandmother, my great grandmother, my great aunts and uncles, my aunts and uncles. And so I just really always loved and appreciated older adults. And I'm an older adult now myself. So,
There you go.
definitely. So it's really, that when I started doing peer work, I was in sales before that, and I really wanted to do something that I felt passionate about.
Mm.
And I'm truly living my passion. I'm helping other people, and it's just great, rewarding work. And I'm happy to be a part of this program and other programs to share what I can to get the services out there for the community.
That's so important, Joanne. It's great. And I thank you so much for your analysis of how agencies are dealing with the challenges of COVID and the technological challenges of working with older folks. Anybody else have a story, a challenge, or a success that you found over the past year during COVID? So what worked for folks during this time to reach the older people?
I know you have stories.
I think over the last year, I haven't worked with too many people who weren't up on how to use technology in the past. So over the last year, that's been a challenge that I've found, trying to help people over the phone how to set up a tablet. I think Elliot would be great about helping members to get tablets, to get access to phones and data plans, so as we can engage in virtual face-to-face meetings with people, trying to explain to someone how to set the phone up if there's issues with connection. I mean, I'm sure we've all been there over the last year of the last virtual meetings where it always seems to cut out at the worst possible time, because that's just how it works. Over the past couple of months, I've been able to start reintegrating some face-to-face visits, which has been, I think, fantastic. I've actually managed to get a lot more done, where I can sit down with someone and be like, okay, so this is your phone. All you have to do is we do this and this. I'm going to put that there. When you want to call me, if you want to call me by video, you press that button. If you want to call me just a talk, that one. And then being able to just give that extra personal touch that does get lost. Calling people, developing a relationship with people over the phone is so challenging, because at times it feels like we're just salespeople. And if somebody random calls me up, I'm like, yeah, okay, bye. I don't really want to talk to you. And I'm calling people when they've left the hospital. So it's, you know, why do you want to know why I went to the hospital? How do you know that I went to the hospital? You know, that's so explaining that, trying to develop a rapport with someone over the phone is a skill. I don't think it's a skill that any of us have quite perfected yet, but I think, you know, it's over the pandemic, I think we've all been very resourceful, and it's gave us some things to think about moving forward with how we deliver care.
Gary, I'm sorry, somebody else was going to say something.
Go ahead.
Would you have found, or would you recommend that the hospitals provide some sort of introduction to the agencies that are going to continue care in the community, like at least letting people know the name of the place that might call them or is going to call them?
Yeah, I think that would be great. And we try to contact hospitals while members are there. Most of the members are already involved with our team, and we have some kind of, you know, background relationship with, but every now and then there'll be a new referral who's in the hospital, you know, so I will call Mass General, for example, speak to someone, they will pass the message on to the patient and be like, Gary who? From where?
Yeah.
I don't know him. I don't want to talk to him now. Don't leave me
I
alone.
mean that. What's that?
Elliot who?
I mean, if it could be not just a service, but a person and a touch point, I think that would make a huge difference. But also, just in this room, I imagine that it's rare for a radiation oncologist, a medical oncologist, folks from ASAP, a psychiatrist, behavioral support specialist, and someone from the more administrative side and people with lived experience all to be in the same room. So there's I think a lot of opportunity to kind of share our different perspectives. I think that in addition to being hard to build trust on the phone, I sometimes have a hard time knowing when to worry medically on the phone, or I am worried. And so I want the person, so I think that's a question about kind of when we do need the in-person touch point, when it matters.
I can tell you, the Cancer Center has had like numerous meetings about that. Like, what should they use some word, what should the recurrence of like in-person versus virtual visits be? The tandem of that, or whatever the word is, but it's really controversial. And then the other thing on our center is that we were seeing patients the whole time. That's one of the unique things about working in the Cancer Center, is that we stayed open. I mean, people needed to get chemo, and so what became challenging for us is we're still seeing people and then keeping people safe. And so then we started limiting who could come to the clinic, and it got in its worst, and we're kind of still getting out of this, only allowing the patient to come in by themselves. And this is huge in oncology and probably in other specialties too, but largely one of the best parts of our job is you get to meet the whole family, and you really, by the time somebody's done with treatment, you usually know their loved ones as well as the patient, and they're filling in all the gaps and telling you what's actually happening at home. And that we just lost. It was just cut off all of a sudden, and then you're just in the room with the patient. And then we do our best to call the loved one and have them on the phone, and that's complicated. And often they're in the parking garage on their phone waiting to take their loved one home after the visit, which is absurd as well. And so that we're digging out of that now. It's actually within the next week, we're gonna start having, I believe, families can start coming back to the clinic, which will be huge. But not having that extra set of eyes at all the visits has been so challenging.
And for people with serious mental illness, I mean, I think it's been really, really hard when sometimes that there's their key advocate.
Right.
And for older adults with mental health disorders, I think it's very challenging for people to, know the information, to think about what's going to happen when you go home, to think about who's going to be helping with medications, even if for just thinking medically, there's a lot of potential for, things to go awry, in addition to it just being really hard and isolating for everybody involved, but particularly the patient and caregiver. It's just harder. It takes that extra step, those extra 3 steps sometimes. We've talked about kind of what would help make it go better. So we've had like 3 questions that people actually sometimes have had people go in wearing something around their neck with, this is who to call. These are the 2 questions to ask. This is the backup number. Because I think for oncologists, if you're trying to reach out to, let's say, a group living environment, people do not know what a community support specialist is, a program manager is. Sometimes they'll ask somebody, I don't see anybody. Oh, you mean my people at the clinic? You have to kind of know the lingo a little bit. That's why these meetings are so helpful, I think, to kind of start. But I think we all need those triggers. So it saves time if you have the phone number to call. FaceTime this number, and that person's there. And the caregiver also, and Carrie, you've thought a lot about this too, for the caregivers, which visits matter most? When do you insist? For mental health care, I think sometimes we need in-person visits too, but I get a lot of pushback about that. I do it because I'm in the cancer center and I, do it. But a lot of people don't agree with me about that. So it's an interesting question, balancing safety and balancing, the fact that people are presenting much more acutely ill from a mental health perspective and are not safe at home.
I just want to add to that. My name is Anil, one of the radiation oncology residents. The interesting thing that I saw when the pandemic first started, when we really started doing a lot of video visits, especially for our older patients, and in radiation we get a lot of patients with advanced age because sometimes it's more tolerated. It's a better option than surgery for certain indications. The one thing I love seeing is when we would do a Zoom visit, and then we would have multiple family members on, even from other states and other cities that could help translate. They would have their own friends come on. And the other thing is sometimes it was just the convenience, with radiation, often it's a daily treatment and we see them once a week at least. The convenience of being at home and the intimacy of being in the private home and being able to see the environment they're in, how they're feeling. I think there was a benefit to the video calls when we could do it. Of course, not everyone had internet access, not everyone had telephones, but if I saw something really that I'd never thought about before, which was, building a connection through video. There's a difference between in-person and video, of course, but there was still something we can build with the video call. And patients weren't exhausted being in the hospital, going from one place to the next the whole day. They were still seeing multiple consults, all just in the comfort of their own home. I think that was really nice for some of our patients.
Yeah, we have talked in the group about the benefits to folks with serious mental illness to not having to make in-person visits. We've talked a lot about that in the group. So it's good to hear that it really does matter to people if they can make a connection through a visual. Let's see. Anybody else want to talk about any frustrations? Yes, Lee.
Working for somebody years with mental health issues, and I also have them myself, I did notice during the pandemic, and I hope this continues beyond the pandemic, is the telehealth video visits, because I know for me, it's just so much better to do that than to have to drive into Boston, or for those who don't have a car, you don't have to wait for an hour for the ride to come in and pick you up, like the PT1, and then wait an hour for them to come bring you home. It just it was just so, and it's like hurry up and wait. Where if you do a video, it's just like you just live your life, have your group or your doctor's visit, and then end the video, end the session, and then live your life. None of this traveling, none of this paying for parking if you have your own car,
Mm,
none of this being on somebody else's schedule. You're on your own schedule. You're not as tired. You're not as cranky. And it was just so much better for people with mental illness as well. I know, I do notice that.
mm,
And, you know, I would love to, I mean, right now I'm not working, but I would love to continue to do, I'm co-ops peer support, digital peer support and regular peer support. I mean, I would love to continue to do peer support over video and just do that. And, you know, as a part-time job, and because I know there's a demand out there for it. And, you know, because not everybody wants to go out of the house just to go see the doctor or to go to group therapy or have a, you know, whatever.
mhm, mhm.
And, you know, it just takes a chunk out of somebody's day, and it's totally unnecessary.
It's really important, important observation. And, I think that one of the things I was going to ask the larger group, how many people have like kind of, seen a clinician remotely over the past year, like, or used telehealth in a way that like worked for them. Did that work for you? I think that so I see my mental health clinicians remotely. It's certainly much easier for me in many ways. I'm balancing a lot of things. And I think overall, because I have access to FaceTime and video, it's like works pretty well. Sometimes I miss seeing my therapist, who I've known for a really long time, but overall we have established trust and we can make it work. But I think for other people, it may not be the case always. I think that, so I wonder people's thoughts about kind of the importance of choice, of asking, of being able to be flexible. And then also as a clinician, I can tell you, it takes so much time to help people get onto technology that it probably doubles my time, and I don't have any support staff to help me with that or scheduling. And so this is like just me being transparent. That's really annoying. And then it leads me to either, it's hard to sustain doing that. So I think we have to figure out how to integrate administrative support into telehealth a little bit better. I think that would make it more sustainable, but also just, I don't know, sometimes phone's great. Who likes phone? Or go ahead, Lee.
You could also utilize peers to help others with learning the technology and everything. You know, like older adult peers and younger adult peers can help the people learn the technology, so it doesn't have to follow the provider.
That would be wonderful. I totally agree. And we have like a navigator model. And sometimes it's hard to know how to find peers, I think, or peer specialists for older adults. I know how to do that when someone's connected to the Department of Mental Health or is linked to an ASAP, but I know it's actually more broadly available. Do you guys have any thoughts about how we could better connect with peer specialists to help with teaching around technology?
Oh, I know some. I
Great.
definitely know
All
some.
right.
I know somebody
that's how
who
things
could
start. It's with that kind of relationship, Lee. So I'll be following you up on that, and I appreciate that. I know Ryan will too.
I'm a older adult peer specialist, but I know somebody who has a whole network of people who could teach technology. He's
And Rob and
peer
Karen
specialist himself.
Yeah, absolutely. That's wonderful. I think so. Let's say like maybe 2 or 3 minutes. We're gonna pull up the whiteboard, and we're gonna kind of think together about kind of what we're gonna present to the session, the larger session. So we want to think about kind of key challenges, what worked well. What are our priorities? What matters the most to us? And then 1 or 2 next steps we might take together. That could be to like a research question we want to think about answering together, or a clinical innovation, or something we want to advocate. But I think that if you have, those are kind of the frame. So that's kind of where we're getting to. We'll be thinking about that specifically to older adults with mental health disorders during the pandemic and beyond. And I know I don't want no pressure, Lucy and Jill. I'm glad that you're here, and there's no need to speak if you don't want to. If you want to put something in the chat, that's great too. But if you did want to share something, I just wanted to invite you to share your thoughts.
And Carrie as well.
So I can just share from my own personal experience. I haven't been seeing patients over the pandemic. I've kind of been collaborating with Kelly more behind the scenes and thinking about the ways in which I can help with research. But my own experience is similarly, whether it's around mental health care, primary care, it resonates with me the ease and convenience of, if I have the resources to get on technology. It's been helpful in managing, being a caregiver to 3 small children and being the one that's kind of on the front lines with them. And it's just helpful from a logistical standpoint, not having to like figure out childcare to drive in, to come out. I can really see the pros of that. But obviously, if you don't have the technology accessibility, I really love the idea of like, how do you bring help, whether it's a peer specialist or somebody even on Kelly's team who can help, the clinicians and the folks who are trying to maximize the amount of time you have to focus on the care versus the technology piece. Like I see that kind of tension, that line of when it can be helpful. And I really love the idea of choice. If there is choice for people to be able to continue some of this beyond the pandemic, for those reasons a lot of you guys have highlighted, ease, like taking down stress for folks who are already overstressed and overburdened. I think that there are some opportunities there. So thanks.
Thanks, Carrie. I mean, I think that we didn't talk. Go ahead, Jill.
Okay, I just wanted to say I haven't put anything into this because, so for the year of the pandemic, I actually did not work that year. So I had been working for the Department of Mental Health as a peer specialist. But because I was at super high risk, should I catch COVID due to, I have lupus, so that put me in a really high risk category. My physician recommended that I take the year off. So I am now working as a social service advocate for the Committee for Public Counsel Services, and I've been remote the whole time since I got hired. But I did, when I worked for DMH, do a lot of work with older adults. And so that was kind of why I joined this group. But I haven't had any experience during the pandemic with it. But I can say that I know, so I of course have my own lived mental health experience, as well as my son, who's now an adult, has a major mental illness. And I can say that the remote options for him, he actually preferred to the in-person. And of course, he's in his late 20s. So he's not an older adult. But he found that the anxiety of going to in-person visits for him made that a lot more difficult. And so he actually has opted to stay with the remote options for like his therapy and stuff moving forward, because it just, for him, it feels better. So I just wanted to share that.
Thank you, Jill. Thank you very much. One other population that we haven't really touched on would be folks in assisted living or other kinds of care facilities. We might want to include them in our future planning and our future research of including folks in research studies to help reduce the huge mortality gap that exists about folks with severe mental health conditions. And
it's so important for them, so important. And I think maybe it's a good time, Carrie, we can pull up the whiteboard and then we can start to kind of get some of these ideas on paper, but I'm so glad you brought that up. I think that we see a lot of people with mental health disorders, aging. We have this 30-year mortality gap. Things are getting a little bit better, but they cannot stay in their group homes. They're not accessible. Right. They are not able to care for medical conditions that people have. And so many people live in skilled nursing facilities, and we know how challenging it has been in skilled nursing facilities. Unfortunately, people lose access to the Department of Mental Health often when they go to skilled nursing facilities. And they say, oh, well, they're cared for. Well, FYI, there's not skillful recovery-based expert mental health care happening often in skilled nursing facilities. There's a visiting consultant every couple of weeks who's overburdened, and that's not the same thing. So that's a really important issue. Yes, Lee.
Yeah, I sent an email to Rob Walker because people with mental illness,
He's here.
you
Yeah.
know, I know a lot from working at ACCS when you can't live alone and you can't be part of the ACCS because you can't live alone or in the community. The only option is a nursing home, and that's because of what Medicaid pays for. But what I'm hearing is a lot of people with mental illness want to go to assisted living because that's where you have nursing on site, but yet you have your own apartment, and you know, kind of like what our parents and grandparents were able to self-pay. And I was proposing to him, why not use existing housing as subsidy and combine that with Mass Health to pay for those kind of services.
Yeah, and Rob Walker is here. He's leading one of the other breakout groups, Lee. And so I think we should talk about that more as a key issue in the main session. It's a wonderful idea. The incentives are hard, right? It's a hard thing, but very important.
I mean, you know, and a lot of those people don't have access to technology because they're in a shared living environment with, you know, and
right.
you know, you only have a double room because that's what Medicaid pays for, and the only privacy you get is a curtain. And you know, a lot of those places probably don't even have Wi-Fi or whatever. You know, and then they're blasting TV, which will interfere with your Zoom conferences.
So I just, absolutely. I just wanted to, in terms of the technology, if you go up to view options, okay, and click on view options, there's an arrow there, and you can click on annotate, and then you will be able to write onto the whiteboard, just like Carrie and I are. Because we want to kind of create this image together. You can say it out loud and we'll put it up there if anybody wants to write on the whiteboard. I just wanted to make sure people knew.
There's no Zoom peer support for people in nursing facilities or shared living type environments like group homes that people could Zoom on. You know, there's like the Metro Boston and all the ROCs have virtual groups and peer support. But, you know, for accessing them from like the nursing homes or whatever, people just don't know about it. And, you know, stuff like that.
Yeah, and if peers are available to build that bridge, that would be wonderful. I think that's such an important idea because, you know, that's a key, just as you said, gap in care. And it's so hard to reach people in skilled nursing when they don't have their own phone. It is almost impossible to do that. We do it anyway with persistence. We partner with staff members to reach people, but, you know, over the past year, FaceTiming, texting, finding someone at the skilled nursing facility who could be there when we couldn't be there in person. Such an important point. So I'm trying to think together with you guys. We've got a couple minutes. What do you think are your kind of the most important priorities for our shared group? When to meet in person, preserving a choice, meeting people where they are throughout the system. What are your guys' thoughts on that?
Kelly, it's Noreen, just along the lines of what you're saying, like choice and being able to meet people where they're at. Maybe related to reimbursements for doing telehealth.
Yes.
Should be something to keep in mind because it will allow choice, and choice will be limited, you know, depending on how future approvals around reimbursement go. So that
and reimbursement for the care coordination to do the teaching around the technology too.
Absolutely.
So that's really important. Is there any, all right, so those are some important priorities. I'm curious from your guys' perspective, if we're kind of building a research agenda here, right? It's our agenda for change, but it's also some things we need to understand better. What are your priorities, or what next steps would you want to take together to learn more about how to solve this? So Noreen brings up a really important issue of reimbursement.
I think when I think of, I mean, I totally agree. I think priority is choice and flexibility to meet people where they are. So I guess the first question is, when do older adults prefer to be in person versus virtual or other technology? I think it's a good question we should ask the patients. And the second is, what do we need to do to increase accessibility?
Yes, and I just, for the main complaint I've heard on this, like on the ground, is like, all right, so you learn it once, but why do you keep using it? With any new technology, there has to be something in it for the person. So like, well, how can this help you in your life? And how can we use technologies that actually help you connect with people in your life in healthcare, so that there's actually a reason for you to want to learn it, not just because that's the system my hospital uses.
Well, I've talked to some of my consumers who are not tech savvy. They've never used a computer. And one person I'm thinking of in particular, I mentioned, first I should stop there and just say that during COVID, and I think it's still going on, all the ASAPs got a special—
1 minute warning.
they got a special grant, I guess, to provide people, to provide their patients with either an iPhone or an iPad. And so I was advocating for this woman to get an iPad, and usually the elder service agency, someone in there will help train them. There are actual companies that do train older adults. I don't know how they do it. I think the person that was working with Rob and one of the other
Karen?
what, I can't think of her name.
Yeah, it's Karen Fortuna. She'll be in the large room.
Karen Fortuna, right?
Yep. It always ends too soon, or sometimes does. And that's a good sign. It means that we were having good, meaningful conversations. And hopefully we can broaden those conversations together. It's nice to see everybody's face as part of the session, and really such a wonderful group of people who are joining here today from across the country, really, but also with such diverse levels of experience that I hope we can really, problem solve and come up with some new ideas together. So that the plan for this kind of closing time is we're going to have each breakout group present their priorities that they generated together and 1 or 2 action steps. We'll go through the groups, and then we'll hopefully have some chance to kind of build a little bit of consensus and talk about our shared priorities and opportunities to partner going forward. So why don't we start with the trust group, since I don't mind calling Amy out.
Yes, Kriya Brown and I co-led the trust group, and actually, since I was cut off from saying a warm thank you to my session participants, I really want to thank everybody in the group. It was a really, really good, it was a great group, great thoughts. Zoe took excellent notes, and we talked about all of these concepts, and at the same time we talked also about how some of the things that we were mentioning are very obvious things like listen, and how much that means to be actually listening, to be actually sitting down with someone, and to be, I think, present. We had a nice mixture of people who've had cancer and people who are clinicians. And I think that it was good to sort of hear that that trust can also be rebuilt, that while it can be stripped away over, over a lifetime of feeling, demoralized, you know, there are moments in time where people feel that their trust is rebuilt by, you know, simple things like someone sitting down and validating their experience, someone listening to them, someone just being there with them when maybe a family member is not able to be there. Kriya, am I missing anything? Or also anybody in the group, feel free to pipe in.
No, I think we were pretty consistent on, you know, the whole theme of the actions speak louder than words and meaning what you say. I do want to say a really quick thank you to Marie, because her story kind of shows that, you know, mental illness, it can happen to anybody. Like, you can be a doctor, you can be anybody. And it's just one of those things that I think is so important just to acknowledge. So I do want to say thank you to her, and thank you to everybody for sharing. It was great.
So
Awesome. Marie, did you want to add anything? So I think I tried to throw, and also anybody who wants to can hit view options and annotate if they feel like typing onto the screen. Was there a key next step that your group talked about?
I don't know that we really talked about a key next step, but I do think that, you know, one of the things then, and I'm only speaking for myself here and not the whole session, but I do think some of what I was hearing is maybe having better training at the professional level for physicians and social workers and clinicians to, you know, to be talking about this concept of trust and, you know, how to be present with someone. I think we lose a lot of that in our busyness and in our demand to move on and move fast. So that was something that I think I was thinking about, you know, in sort of a next step way. Kriya?
I would second that, but also going a step further, like past the clinician. So also for us that aren't licensed yet, or it's still trying to figure out where we're going, just anybody who is going to be engaging with a patient or engaging in the work should have some sort of training on, you know, where to start. And I think, you know, the action steps really could be the things that we felt were like so obvious, or like things like just showing up when you say you are. Like, those are things that are actionable within our control for the most part. But yeah, those are my thoughts.
Can I just add one thought very quick? That the model at MGH, right? You express a need, a concern, an emotion, and it is not only heard, but somebody takes action to help you. Like, that's the theme that's coming through here, that my social worker showed up every week. My whatever my needs were, she helped me through it, because between chemo and my memory, and I had no family, I had really not anybody to help me through this, so I really had to depend on this team. But somebody else also mentioned the community aspect of everybody communicating as a team. So you not only have one person that cares, you have a whole team of people who see you as a complete person with individual needs, and then they connect you to the resources that you need. And it's a package deal. So just a thought.
Thank you, Mary.
Absolutely. And I think it's a question going forward. How do we measure that? You know, how do we measure whether we receive the care like that, or whether we are building trust, or people feel seen as people? So good questions to kind of think about going forward. Let me go to the digital tools session, and please feel free to add your thoughts in the chat too. If you're thinking about, all right, I've always thought about how to measure trust and like what I would want to see change. There's a lot of really thoughtful people in the room. If this has spurred questions and you want to put them in the chat, then we'll capture those. Ben and Celeste, do you want to go for it?
Sure, I'll just share my screen with our whiteboard.
Thank you. This is the Access to Mental Health Care group.
Here we go. And Ben, are you?
Yes, I'm here.
Oh, perfect. Okay, good.
Well, just to briefly, you can see at the bottom the key points, themes, priorities. I don't know that we had time to get to the action steps. We really managed to, I think, include just about everyone in the discussion. A lot of the discussion, reflected upon, sort of issues frankly, with interpretation for these communities. And just the some of the barriers that exist around that, and sort of needing to address those concerns for access to care. That this is something that's happening in a variety of environments. Sorry, just looking over this. So I think the other thing that we heard about at the end from Dr. Bartels was, some toolkits that were being developed that actually really sounded like something that would be of interest to certainly our community of practice, and as potentially something where we're very much aligned in terms of our goals. And so certainly I thought, listening to him talk about those tools kits, that we need to, that it would be valuable for our entire community to really look at those and see if they're applicable to the work that we're doing. And we sort of heard about that at the end as being kind of a success story over the last year, in terms of and really kind of getting at the bottom of the discussion about the digital divide, broadband access, just that even though there are these reluctances to engage with these technologies, they're just not accessible broadly. And so how do we, as a community, try to actually figure out how to increase access just on the gut community level, so that it becomes a choice. So those were sort of broadly the key points and themes and priorities that we discussed. But
there was a question in the chat. I think we were talking about kind of guidelines offered by SAMHSA to care for older adults with mental illness and substance use disorders. It's interesting because we're kind of, one of the things we're putting together is guidelines around kind of how to increase access to research for our population. This is wonderful themes, a lot of really good ideas here. Thank you so much.
And I think it would take a quick Google search to actually identify the center, right? That Dr. Bartels, and he unfortunately had to leave, but I think
that's okay. No, he's pretty. We're all in touch.
Right.
To advise, and I know he's going to be actually using the feedback to help inform the guidance for older adults with serious mental illness. That's a kind of high impact. Like I want all of us to be able to reach. It's really important to come together to inform guidelines in addition to research questions. Celeste, is there anything else you want us to add before we go to the next group?
I was just going to say, I think Amy brought this up with the trust group, is we found ourselves talking about making sure providers themselves are educated about the pitfalls in virtual care. Sometimes it's just not going to be within the provider's awareness of all the ways that the virtual care visit could kind of go awry, or what's needed actually to have a successful virtual care visit. And we felt like that might potentially be a really good first step to take, because it's very much like within our domain to be able to develop a training for folks about how to do virtual care well with underserved, disenfranchised populations.
Yeah, that's really a great idea, and how to also measure the impact of it if you were going to pilot a new approach in terms of what that we might see. Would that lead to fewer missed visits, people having a better experience with care, fewer hospitalizations, better health outcomes, better clinician experience, less clinician burden? So that's just to kind of get us started thinking. Thank you so much. All right, we'll go to another group. Karen and Rob, are you out there?
Yeah, we had a great group of researchers, and we talked a lot about the different levels of community engagement, from running focus groups on one end to real side-by-side engagement with the target population, with patients or service users that are with you every step of the way of designing the research or designing the intervention and implementing it. So we talked about about the more successful interventions are ones that were designed with in a full partnership. And we just talked about the challenges with getting an intervention up and running and going. And we talked about having the most simple intervention, the better. I think Joe talked about the way the digital health works with his physician is you get a text, you click on the text and you're connected with the physician, just one step. And once people get used to using the technology and finding out that it's not as daunting as it seems.
Yeah, and I'd
That
like to
is,
open. Sorry, Rob, what'd you say?
no, go ahead. No.
No, I just wanted to open it up to the rest of the group, that we, within our smaller subgroup, about, anything else that we may have missed in our summary for folks.
I just think the only thing that really seems like across the board, a lot of people are discussing is how to split what's delivered in person versus synchronous virtual versus asynchronous virtual, and really thinking about looking forward to solving kind of the hybrid approach of delivery of care and research.
Mm-hmm.
I have a couple notes too, but I think we've talked about most of them. I'll try to share it. So we talked, just like we've just been saying, we talked about that technology and the access to it. Who are these people and where are they? Those were some of the discussion went, and the ownership actually of the technology. How do we develop an intervention that has either or both synchronous and asynchronous venues, and need to get technology into the people's hands? And then even though our group wasn't on the trust, we also talked about the trust and credibility, and how that really does make it difficult and often causes some hesitancy to even use the technology. And then the last thing I had was real human factors. And I think that was you, Dr. Fortuna, that you mentioned that.
Wonderful, but that's great, important ideas. Let's go to our Spanish language session with Gabby and Danny Jimenez. Okay, and I want to make sure that the closed captioning is available for anybody who wants to listen to this in what language is best for you. Go ahead.
Okay, so hi everyone. So our group was awesome. Feel free to jump in if I forget anything or if I misspeak. So first we started with what was causing the divide between Latinos coming in for mental health issues and stuff. So we first started out saying that stigma is a big part of why they're not coming in. Access to technology, the funds, all of that, the knowledge, lack of trust. So we came in and we asked, how would we be able to bridge that divide? So we threw some ideas around, like normalizing it, that they're not the only ones going through this. Sometimes staying away from medical terminology, just saying it's for your well-being, that you're there to help. Also keeping it confidential. So telling them that whatever they say is with you, not, you can't speak to it with anybody else. And one of the steps that we had got to, because the time ended, was education. So just from both sides of it, like the training for the clinicians and the community healthcare workers, but also educating the patients coming in. So if I forgot anything, just jump in.
No, you did a great job, Gabby. And I would also like to say that the discussion was great, and was as most breakout sessions are, right? We ran out of time when we weren't able to really dive deep into a lot of these topics that were brought up. And but I would like to add that one of the things that was really important was building trust and social support. So building trust from an organization or institutional perspective, right? being a part of the community, being visible in the community, being a part of the community for a very long time, showing your commitment. And then also the importance of social support, whether it be through, having like group therapy, or having programs where you have peers that are in this together, sharing their experiences, really adds to that. And then one of the things about we touched briefly on technology, and like Gabby said, education was really important. Education on how to use technology, education on how to use some of these platforms like Zoom, but also one of the members, Jeanette, mentioned about investment, and that it's really important that institutions, organizations, governments really invest in technology and giving access to these folks that we're trying to reach.
Yeah, and in a way that they can use it and works for them. And just as you said, I think these are beginnings of discussions that hopefully will spur more dialogue. Our last group is the older adults group. So just if Carrie, you want to share the thoughts, and Ruth Ann, do you want to summarize some of the key takeaways?
I can say that we touched on many of the things that all the other groups have touched on. What I particularly like to focus on is that there's a wide range of abilities with technology, but many seniors who live in group settings like a senior high rise or a senior might know how to already access the internet and use it. We can use technology to connect with cancer patients not being able to bring family members in. We can use technology to connect with their support systems and their families, even if they're at a distance. People need choices. They want to have a choice whether they want to make their visits virtually. And of course, that depends on whether they have the equipment and the knowledge of how to use it. We also found out that the area agencies on aging, which usually are aging service access points, the senior agencies, some of them received money during COVID to provide devices to individuals so that they could be in touch with the support system. We also touched a little bit about the importance of peer specialists, people who have training and lived experience, whose job and passion it is to reach out to others and try to assist them through visits, conversations, phones. It's hard to develop trust over the phone, but it can be done. So what else did I forget?
I think you did a great job. I think that was great. And I think just this idea of bridging across, what peer specialists have to share, what people from elder services have to share, what an oncologist perspective is, what a mental health clinician's perspective we can learn from thinking about it from the perspective of someone who is a service user or someone with lived experience and what works in actual life. And I think we just have just 2 minutes. So I just wanted to really thank all of you and say, I'm glad you felt that it was too short a time. That's a good sign. That means you care about this and you've got ideas. And so we're going to put the link to the feedback form right in the chat, and we can send it by email. And in that, yes, we'll ask for but mostly it's what do you think matters? And do you want to be involved, and in what way? So that we can continue to work together, to increase access to the care that everyone deserves and bridge this disparity. So I found it incredibly inspiring. I also wanted to share that, I know there's always things to get better in terms of accessibility. So we're always open to that feedback. And just really to thank you for spending these 2 hours with us and being so open with your experiences. And in particular to Carmen and to Dottie and to our members of the community of practice and breakout group leaders who are so generous with their time and ideas. So hey, Kelly, how do I access that feedback form? That sure sounds like a wonderful thing to fill out. So there you go. It's there in the chat. Ahí está. Es el momento del tiempo. Oh, ya ahora.
Me falta la práctica de español de mi tiempo en El Salvador, así por eso this has been fun for me. It's been something I've wanted to do for a long time, to have a Spanish language session, and I'm really grateful to everyone for partnering us in doing that. And also the real focus on bridging to skilled nursing. I think it's you know, a really wonderful group of people in the room, and I think everybody doesn't always think about themselves as a researcher. So just for full transparency, I didn't really think about myself as a researcher either. That doesn't need to be like such a big thing. It means you care about making a change in the world, and you have an idea, and we can work together to figure out how to measure that and then implement that. So it really does take all of us together to kind of create that change, and not, you know, fall back into that trap of returning to normality, as our Daddy Roy would guide us.
Hey, Kelly, somebody had, Lee had a question in the chat on what age does older adults start at?
Gosh, it's variable, eh? 65 for ASAPs, I don't know, 60 sometimes, I don't know. What do you think, Matt?
Well, we used to be friends, you and I.
We are friends, so I can tease you.
Well, I think you should have said 1 year older than Matt Lascalzo. Really, now that I'm 69, I don't know.
I'm almost there.
I just wanted to say, for peer specialists, we work with a community that's 55 plus, and it could be younger for people that are disabled.
I love that. And, you know, I think for people who are living with mental health disorders, given premature mortality, often people are coping with the issues of aging at age 50 or earlier. It'd be wonderful to be able to access the services earlier. And it's actually a really important question about how we define that and what makes
Kelly, it is such an important question, especially if you look at function, because we know that there are people who are 35 and 40, and because of either treatment or because of life's challenges, because of genetics, they really are much older.
Mm. I know our geriatric oncologist, it's about functioning, right? We don't want to define people based on age or disorder. And it's 12. So, I mean, I'm happy to stay on and answer questions. I don't want anyone to feel obligated to. I really appreciate everyone's time, but I'll be here for 10 minutes if people have questions or just to catch up. Thank you so much for spending your time and for joining us.
Awesome.
Dorothy, you're here from Ireland. It's wonderful that you're here from Ireland, Dorothy. That's awesome. Thanks, Kelly. My pleasure.
Bye, Kelly. Take care.
Absolutely. Thanks, Veronica. Appreciate you scribing. Ruth Ann, thank you for the wonderful facilitation too. Hopefully
I appreciate all the participants today. We had a wide range of expertise and lots of good conversation. Thank you.
Yeah, Joanne, thank you so much. I really appreciated what you had to say, and I found it really resonated with all of us. I hope we can continue to work together.
Yes, I would love that. Thank you.
Mary, thank you so much.
Bye, Kelly. Good to see you all. Thank you all.
Good to see you too. More to come soon.
Thank you so much, Mary.
Bye.
Bye. Tina, so just from a logistics standpoint, do you have the chat?
Yes, we have the chat. All
Okay,
set.
awesome. And the recording. I'm doing one, so I'm going to stop it now.
That's good.
Okay. I don't know if other people are also recording, but I'm going to stop my